So at meetings like this, it's almost the rule that that no matter what the topic of discussion is on the written agenda, that eventually at some point the topic will drift towards healthcare information technology. And I don't have to tell you all why that happens, and I don't have to tell you about the havoc that health information technology has wreaked upon our practices. We've heard several speakers talk about that today. I will give you two more statistics to think about, one of which is pretty fresh. This was published in the Annals of Internal Medicine on September the 6th, and it was a very sophisticated time motion study of how we docs spend our day. And it turns out with a health information, an EMR in place, that we are about 25% efficient. That means, it's not exactly the same statistic, but for every 60 minutes that we spend in face-to-face contact with patients, holding their hand, talking to them about what we can do for them, we have to spend another 90 minutes touching the computer. And that's just not acceptable. And as if that wasn't enough, we have to spend another 90 minutes at the end of every day, at home, after the kids are in bed, whatever, catching up on all the stuff that we still couldn't do during the day, even with that 90 to 60 ratio. The other statistic I'll give you to think about is related to health information technology, and it's quality reporting, and we're all so fond of quality reporting to CMS, that the annual cost just for PQRS is about $15.4 billion per year. Now, how much money is $15.4 billion per year? Well, at $10,000 per capita, that's enough for healthcare spending for 1.5 million people. And that's if you do it inefficiently, right? If we gave it to this crowd to take care of at $50 per person per month, we could cover 25 million people. And that doesn't count the drugs and the other things, of course, but at least in terms of the annual fee, we could cover 25 million people with the amount of money just on PQRS quality reporting alone. And the real tragedy there, especially for me as a health IT guy in addition to being a doc, is that we're losing sight of all the potential this stuff could have. It could be so much better if we didn't have the feds ramming this down their throats with their sort of top-down vision of how things are supposed to be. And that's what makes this panel very exciting and very interesting, is because with direct primary care, we can walk away from all that stuff. And we can do health information technology the way we want to do it, to serve the patient's needs and to serve our needs. And so under that category, there's two things that excite me. The first is the whole concept of telemedicine. When we don't have to get paid, we don't have to bring patients face-to-face to get paid, we're free to interact with those patients in any way we wish. And Dr. Jeff English, who's with me in Atlanta, he does clinical research at the Multiple Sclerosis Center of Atlanta, is deep into the telemedicine, and he's going to tell us about that first. The other thing that's very exciting is this whole thing of what does an EMR look like that doesn't have to genuflect to all of these regulations that come out of Washington. And Dr. Randall Oates is going to tell us about that. He's the CEO of, Soapware, and they have a DPC dedicated product. So we're going to hear from the two of them, and I'm going to get out of the way. Dr. English, you're first.
So first of all, I want to thank everybody in this room, whether it was the speakers, people I've gone to Washington, D.C. with. I mean, my feeling is that, the revolution in healthcare really is direct pay care, especially direct pay primary care, and most of you guys are primary care physicians with some specialists. So I want to thank you. I think Brian Hill, and I'm sure a lot of the other people will say the same thing, but Brian Hill was the first one that said to me, and I remember that, we're never going to fix things in Washington, D.C., we're going to fix it at the local level, and you guys are really doing that. So thank you. So I have become an expert on how telemedicine works. I am the IT people's dream because I have no idea how the actual nuts and bolts work, and I need to call them all the time to help fix it. But I really know how to kind of use, so I know what technology is supposed to do. Mike can tell you much more about what it does. And I'll tell you why I got involved, years ago with this. And I think, again, this is just an incredible application for direct pay care. We'll talk mostly today about primary care, but Brian Hill alluded a little bit to once you start integrating specialists, why this will also revolutionize healthcare. So I got into this for a couple of reasons. I'm in medical school, and turns out I have two of my fellow classmates in the audience here. I remember them telling us that we were supposed to kind of have the diagnosis just by talking to patients down to about one or two things in 85% of our patients, right? And I realized that my patients were driving like 4 to 6 hours to see me from surrounding states, just to spend 15 minutes with me when 85% of what my job was just going to be to talk to them. The exam and the test really just solidify the diagnosis. So I thought, well, okay, this is a really good thing for neurology, right? Because we just kind of talk to people. I kind of learned how to use a pin and a reflex hammer. But mostly it's just kind of talking to patients and getting a clinical history. The first satellite clinic we set up was in Valdosta, Georgia, which is 4 hours without traffic and construction, et cetera, each way for my patients to drive up to see me in Atlanta. And the primary care doctor's office, he said, really, Jeff, I only touch about 10% of my patients also. It's really just kind of talking to them. I got to use the otoscope and things like that on occasion. So, clearly neurology, psychiatry is where this kind of started. Acute stroke care in a hospital with a doctor seeing the patient. But I really think that, so much of what we can do via telemedicine. The technology has gotten incredibly sophisticated, and I can do probably as good of an exam in most cases, sometimes needing an assistant on the other end. So clearly I can get my history is 100% as good via telemedicine as it is when I'm in the office with a patient. It's really just the examination that can suffer, and now I can see all the MRIs, et cetera. So I can really do, I think, equally as good of a job. Heck, as I said, we're, the military, et cetera, we're doing robotic surgery from distances, so I should be able to, see a patient with telemedicine. So, we're talking today about the future of healthcare. Well, a lot of it's, where are people going to go for healthcare, right? I mean, where are they going to get information? You're seeing this transformation already as Mr. Goldhill's, mom is using her iPhone and using the computer. You look at this generation, I mean, these people are not getting out of their office to go see a doctor about a blemish on their wrist or in their throat. I mean, heck, you need sophisticated otoscopes and computers now, but you don't think the iPhone soon, you're going to turn around and the camera's going to look down your throat and you can send that picture to your doctor? Clearly, you can send the skin pictures. As a neurologist now, with half of what I do is multiple sclerosis, and these drugs I have are really effective now, but I can kill you, and I have these crazy, skin lesions, et cetera, and wouldn't it be great if my patients who live 4 hours away could just take a picture and send me and say, hey, is this something I have to worry about, or is this just a bed bug, which it turns out to be half the time. So I think the future of healthcare, when we were in training, I went to Dartmouth Medical School, there was this real, even though it's a very primary care driven school, I really felt like everything was kind of moving towards specialists. Well, it shouldn't have been, and it doesn't need to be now, and I think it's all moving back into the primary care doctor's office. The specialties are not going to go away, and the information's not going to go away. And now, my God, what are we going to do now? People are wearing these recordable devices that are going to send you information on their diabetes and their glucose and their COPD, and you're going to have to learn what to do about that. But I think that I'd like to get most of healthcare, 80% of it, back into the primary care doctor's office, referring to specialists less, and as I'll say in the future with direct pay care, especially primary care, I don't want them coming to your office either. I want them, in Mr. Goldhill's office. Wouldn't it be great to have a room where patients could go to communicate with their doctor via, telemedicine, and not have to leave their office in New York and go see their doctor, who might be 30 miles away, and it still takes 4 hours in New York traffic or Atlanta traffic to get there. So I think that's where things are going, and I think we can get pretty darn good complex evaluations. So I became involved, as I said, we take care of MS patients from like 23 states, most of the counties in Georgia, and it was just killing me that these people were driving 4 hours for a 15-minute follow-up visit. I mean, I just thought that was insane, which is why we started doing more MS care. As you look at this picture of Georgia, I don't have a pointer, but up there where the MS Center of Atlanta is, there's 2 MS centers there, and directly east, there's another MS center, and that's it. That's all they have, and the closest other ones are down in Florida or in Birmingham, and so people were doing all this driving. So my predecessor said, hey, why don't we educate, why don't we travel, kind of like, again, back up at Dartmouth with the traveling doctors, the traveling neurologists. Well, that really was not very cost effective to send a doctor or teach a nurse in an area that might have one MS patient. But now, I can be everywhere now with telemedicine, which is kind of where I really got started with this. We also do telestroke with hospitals as well. Why do I do telestroke? Because it takes me probably an hour to get into my hospital to see a patient, where I can do a telemedicine visit in a patient in New Jersey in 5 minutes. We're making a decision for TPA, where it used to take me an hour and a half to do that. So, this is just, obviously where things are going to go. So, telemedicine, I always say, you kind of been doing it all your life. You've been using the telephone, talking to patients. That's sort of the first telemedicine. The quote of the definition from the American Telemedicine Association doesn't really include telephone, but it really is any exchange of information via any electronic form where it's for the benefit of the patient. And I would encourage anyone who's interested, you can get on the weekly email list from the American Telemedicine Association. They send information all the time on legal updates, Washington, D.C. and states and things like that. And again, the telemedicine is going to then expand, as I said, into recordable devices for chronic disease management, which we'll see. So one of the companies I work with is called Virtual Medical Staff, and that's where they kind of send me teleport into the acute stroke environment or acute neurological stuff. We have one of our hospitals that doesn't have a neurologist most of the time, so the cart goes onto the floors and we'll see patients, because, I think you and me in the room with the patient is the number one best health care, but number two is telemedicine, 3 is phone, and 4 is, hey, sorry, we just don't have access to a doctor, and I refuse to ever let 4 happen, and I don't think 3 has to happen either. But there's also, which we'll talk about for direct pay primary care, I think the just software connecting you guys to your existing patients. And when I talk about telemedicine, when I go to the ATA meetings, I'll sit there for hours in these legal, the legality of telemedicine, these conferences, and they've got lawyers from around the country in Washington, D.C. So, that's an important topic. And also, well, who's paying for this? Well, as Mike had mentioned, with you guys in direct pay, especially if it's an X number amount a month, you're going to use telemedicine. You don't really care about who's paying because it's covered in your monthly cost. All you care is, how do I use this legally, and how do I do it to best, keep my patient in their office without coming in, and how do I connect to specialists? How do I do follow-ups via telemedicine to see my patients? One of the things that lawyers always say, and it's true, as you've heard today, what we're doing is light years away from what the laws, the laws are way behind, right? They always catch up to what we're doing. Hopefully, direct pay care will be 10 years, a solid foundation in the country before people in Washington, D.C. scratch their head and say, hey, maybe Blue Cross wants to have a law on this or something like that. So, you really have to sort of focus on your local laws, your state medical board. What I would say, number one, there's 2 things to kind of keep in mind with telemedicine. Right now, the national law is that healthcare is occurring where the patient is. So little did I know, you think about it, if I'm licensed in Georgia but not in Alabama, but my patient goes to Alabama and actually I'm connected with them via telemedicine or on the telephone, and I tell them what to do. You're actually one of the legal interpretations is I'm actually illegally practicing medicine in the state of Alabama because that's where the patient is. So there's some legislation about flipping that around and saying, well, the patient should be able to access the doctor wherever the doctor is, as long as the doctor's following their local laws. Now, I know Hal Schurz especially is really afraid of that because that's kind of national licenses and things like that. So, what we're probably going to see is more of a hybrid where there's state compacts where I have a telemedicine license in like 13 states, but I don't have full licenses and things like that. So, those are the things to keep in mind. The other thing is just, I shouldn't be holding up my cell phone here and say, hey guys, wait a minute, and doing a telemedicine visit with a patient. There's the HIPAA compliance is the other thing. So if you embrace this, if you bring it in direct pay care, I would just always say, you have to make sure you're in a secure environment when you're interacting with the patients, and obviously keep up with the state medical laws too. So we're in Texas, so I pulled up the Teladoc thing. You guys have probably heard about this lawsuit. The Texas Medical Board said that doctors would have to see a patient in person before they could use telemedicine, because you have to set up a doctor-patient relationship in person for the first time. And obviously, Teladoc wasn't doing that. These were people who were just calling them. So, you know, the most of the laws are in each state. The medical board will tell you, you know, what's the establishment of the doctor-patient relationship when you're using telemedicine. So again, with direct pay care, you don't really care about that because these are your patients. So as long as you've seen them before, that's fine. In my state, it's a little bit different. So what I kind of fall under that second bullet point. I'm able to use technology that makes my examination equal or superior to what they have available. So obviously they have no doctor for acute stroke. I'm doing acute stroke. I fall within the guidelines. Also, number 3 there is more what Brian Hill was kind of talking about. Well, what about patients in your office, and you guys pick a network that you're on to do telemedicine, and then you bring in a specialist. Well, the specialist can see that person, because most states, you'll have to check your state, but Texas is the same, that if the telemedicine consult is at the request of another physician in a medical facility, then that suffices for the establishment of a doctor-patient relationship too. So those are kind of the key things you sort of see with the laws. Georgia was very pro telemedicine, so they kind of set up some other things, like in nursing homes and public schools. They really wanted it to flourish, so they added those things in there as well. So, you know, as I said, you know, I think DPC or telemedicine for DPC, because not only do I not want your patients to have to come to see me, I'm trying to put myself out of business. I also don't want them to have to come to your office unnecessarily either, and I want you to do more frequent follow-ups via telemedicine, and you guys don't have to worry about billing. We're not going to get into this, but each state has different laws on if you can bill for a telemedicine service or not. And another great thing is some of your patients are like in nursing homes, so their children are there in the nursing home with them. They don't have to, you know, bring them into your office, which is such a cumbersome thing. They can connect, you know, with you, with your patient directly in that nursing home, and that's another great example. The patients are going to demand it anyway. You know, as I would say, you know, which I showed you the kid generation. I think probably, I'm 47 now, and I still kind of like to go to my doctor, but he's actually just through a tunnel, so it's not that hard. But I would think probably the age cutoff of more like a 50 and below, a lot of people are probably would rather see you via the computer for many things as opposed to coming with you. So the real, basically with, as we said, the legal issues are the biggest issues. You don't have to deal with billing at all. Different examples I could give you on ways you could bring this to your office. More elaborate would be a group like evisit.com. I really like that group. They've got a telemedicine platform, and you can actually do your notes out of that. You can send e-prescriptions, download videos, imaging, etc. A little bit more pricey. It's about $250 a month per doctor. Unlimited amount of patients, but that gets a little costly unless you're going to build that into your service. And I'm not necessarily sure that you need that. They have the benefit, though, of if you have also a specialist on the network, the specialist can actually, they have billing services through that, so the specialist could see the patient and actually bill without the patient ever having come to see them. But I kind of like the other ones, like VC and Lux SCI. It's about $50 a month, which is easily affordable in your model. And essentially that is just the secure network. So it's a secure network, computer to phone and phone to computer, or computer to computer. So much more reasonable issue and compliant as well. So, as I talked a little bit about before, Brian Hill had mentioned, is there a way, people are asking about how to integrate specialists. Well, this may be a way if you had 3 or 4 specialists that you call pretty frequently, like Nan, how you doing? Nan calls me a lot. We could actually be on the same network, and it would be a way. So maybe if Nan, for instance, picked 4 or 5 specialists that she calls a lot, if they also paid the $50 a month, you can actually do it that way, and I think you could then bring specialty care certainly into your practice. So the e-visits at reduced prices that Brian talked about. So I won't really go over the billing too much. So again, in summary, I think it's a great way to to improve your care of the patients that you have. If it's 500 or 600 patients, the future will bring in specialists. There'll be different ways other than the ways we have alluded to in the last two talks. As I said, it's the wave of the future anyway, and patients are going to demand it. I guess the last caveat I would leave you to is, again, from a legal standpoint, if I was going to do this in a DPC practice, I would make it voluntary for the patients, and there's all kinds of forms you can pull off the ATA website that, people will give you, the patients will give you consent. You can explain what this is, and it's a type of healthcare. You're voluntarily doing it. You think the standards are, equal, but, you'll always tell patients to come in if there's something concerning. So you kind of have, kind of a waiver in that fashion.
It's a real pleasure to be able to be here with such a passionate group of folks that are really wanting to improve the quality of a broken system, and I'm just really honored. And I guess the reason I've been asked to come and talk about kind of some of the EMR, EHR, health information technology issues related to DPC is because I've earned some of these gray hairs. I started out, I did a little over 20 years in a traditional family medicine practice in Northwest Arkansas, and absolutely loved primary care, but I detested charting. It was just in the way, and ironically, because I hated charting so much, I wanted to be face-to-face with patients and not texting while I'm driving through patient encounters. And so I and a group of doctors, we got together, rolled up our sleeves, and actually wrote the prototype of EMR that now is widely distributed, that would help to make the EMR less of an intrusion. And I really appreciated David Goldhill's discussion this morning, and it really summarized a lot of what I see, and that's that the opportunities are with the transition of the Corp Gov Med offerings. We're going to be faced with a scenario where most of the population is going to be looking at limited choice, higher costs, lower quality, and nobody's happy with it. And ironically, you look at, I look at banking, I look at retail. I remember when I used to have, if I needed to do banking, I had to go to the bank. It's been years since I've been in a bank. And retail, gosh, I rarely go into a retail facility anymore. And it's just a matter of time, particularly as more and more of the community is going to have to be paying basically for their health care. They're going to want the same type of service. So I see a real opportunity for those of us, as he pointed out, the focus being on service, on quality and efficiency. And that looking at then the health information side of that, there's a real core difference in the goals in a DPC practice and a traditional practice. In a DPC practice, you're really looking at how can I deliver the best service and efficiency, quality. Whereas in a traditional practice, you really have to focus on productivity. How many can you see and how compliant can you be with all the reporting? And so, that right off the bat triggers a whole different set of priorities, where we're looking at, what I used to call telemedicine after Mr. Goldhill's presentation. I like virtual home visits. In the point of care, as you stated, it's where the patient is. It's not where the clinician is in some facility. That's what people are going to expect. So we need, and as you're doing this, you're putting together tools that allow you to deliver the point of care where the patient is. And that means the patient is more involved. And that's how you market, by delivering that convenience and efficiency. That with your arrangements, with your membership model, you're no longer stuck to the tyranny of the office visit, where everything has to be done in the office. I mean, we all know, so much of what we see is it doesn't require an office visit. Let me say I got fed up about 10 years ago with the system and opened to the best of my knowledge, was the first DPC practice in the state of Arkansas. And after several years, though, I'm too distracted, travel too much to really do service. But I'm still very closely aligned with my original group, and a lot of what I'm doing is in the work of what I call hybrids, where practices are making a gradual transition into direct pay models. But I know EMR is kind of a dirty word in the community. It really is. While it is the kind of the central point and the focal point in a traditional practice, it's really it's a necessary evil for all of us, in that we've got to have a medical legal record that's reproducible and shareable. We can't get beyond that, but that's where the similarity ends. And to point out some of the differences, as you look at solutions for your direct patient care practice, if you look at just the EMRs out there, there are what I call 3 broad categories of offerings. There are those the EMRs that, with some bolt-ons and with some ingenuity, there are products that can work both in the traditional model and in the direct patient care model. And that's just a few, really. And then there are a few that are absolutely saying, get rid of the traditional model. You don't need to be concerned about that. And they've really optimized their offerings to serve the DPC community. And then there are those, and the vast majority are those that are serving the traditional model, and they're just too cumbersome to really be used in a direct primary care practice. And by cumbersome, let me kind of explain what I mean by that. With a EMR or with health information technology in your practice that is truly designed for service and efficiency from a patient perspective, you're really looking for an EMR that's designed and focused on convenience versus traditional, which is compliance. You're looking at products that are really clinician and patient-centered. It's truly a patient-centered medical home approach, whereas in the traditional model and traditional PCMH, it's not the P is process. They're process-centered. There's a big difference in the workflow and how things operate. And I would argue that in the traditional system, the focus is on having good documentation, good charting, where you people can focus on good patient results. So the technology has to be very different in that setting, and as you look at solutions, that's what you want to be focused on. The real core difference in the workflow is that traditional systems are really more focused on managing the data, and whereas in a solution that you're looking for, you're wanting something that facilitates humaneness and caring, something that gives you more face-to-face time rather than face-to-screen time. And as you look at systems and how they're designed and how they operate, you can see a big difference in the philosophy and the design of the two. And your documentation can be concise and efficient, whereas with the traditional system, it tends to be very verbose, a lot of data, often which is meaningless, not meaningful. And so that's what I would be looking for. You really want a system that allows you flexibility and your focus to be on empathy and caring, whereas in traditional systems, they're really focused on promoting uniformity and protocol. It's a big difference there. What you want to be focused on usability. Most systems are having to focus on meeting mandates and regulations. You have the opportunity to really be interested in innovation, whereas a traditional product typically has to be concerned with certification. Big difference. And I would argue that instead of having to complete your documentation after hours, it really should be completed during the encounter in collaboration with your patients. So, in summary on that, you're really interested in a system that through service, it does your marketing, it is convenient and focused on service, whereas a traditional system is going to be looking at creating claims, reporting, and doing the collections, compliance with payment rules and regulations, and productivity. How can we crank the most in? You know, there's that hamster wheel. And I would argue that the end result of health information technology in the traditional system, as has already been pointed out and will be pointed out again during this conference, you know, it's higher total cost of care, where you can actually offer lower total cost of care. It's lower quality of care, distracted, burned out clinicians meeting compliance, where you can offer a higher quality of care where you're focused on the relationship. You're more satisfied. The patients are more satisfied, where in the traditional system, we're seeing less and less satisfaction all around. And I would argue, you know, the whole mantra of we got to get to a healthier population, you do that through healthier individuals. Healthier individuals in sum makes a healthier population. If you go about it the other way, saying we're going to take a population approach, you don't get the same results. And with your model, by going direct, you can really celebrate diversity, whereas in the traditional system, it's focused on consolidation. And so, you know, my personal recommendations as you look at solutions, it's unless you go a pure DPC route and want a system designed for that, you're really going to have to look at putting together solutions to meet the needs that are unique to you in your practice. Like I said, you've seen one DPC practice, you've seen one DPC practice. But I really see that in the future that there's going to be a real growing recognition that DPC plus some type of wraparound is succeeding, where all these advanced practice models, you know, ACOs, PCMH, all these systems are just not failing. They're actually costing more, while the DPC community has results that are showing, you know, 20 to 60% cost savings. You know, that can only be ignored so long, especially as the money is drying up and as our population ages. So I think that the traditional system is going to embrace more and more what's basically simple capitated primary care, and then some type of wraparound for the rest. And so as you look at solutions, I wouldn't write off the system just yet, because that may be the bigger opportunity. And as DPC gets out of its niche into the adoption by the masses, I suspect it's going to be more of a hybrid approach. And with that, I'm going to, I mainly, rather than do PowerPoint, thought that the open discussion back and forth would be more fruitful for the radio audience. So I'm going to keep it short and go from there. Be happy to answer questions what I see is that everyone has gaps in offering that service to their patients. They may have an EMR. If you've got an EMR, you probably want to keep it because it's going to be in the background anyway. But how can I create connected care, and that which I can manage referrals, that I can deliver virtual home visits, and still create a medical record, legal medical record that will stand up under scrutiny. And I see a lot of innovative, creative ways to do that, and it's an exciting time and exciting place to be. Thank you very much.
All right, while we're waiting for folks to come to the microphone with questions, I'll throw a couple out of my own, and whoever wants to jump in, give it a try. In addition to other stuff I do, I'm the compliance officer for our network, ear, nose, and throat of Georgia, North, and Atlanta. And part of the grim tasks that I've got to do is review chart notes for compliance, which is, about as fun as a hemorrhoid under local. And there was one particular doc years ago who was just an old country doctor kind of guy. His notes were never compliant. They were the med students who have never seen a note like this. It was one paragraph, but that one paragraph really had everything you needed to know. And those notes were readable. And so as the compliance officer, I had to enforce the creation of notes that weren't readable, as we all know. So my question to you guys is, does a DPC-enabled EMR system allow us to create documents that we can actually read?
Absolutely. And I would say that that's another big difference. An EMR solution for direct primary care really is, it puts as a priority the patient's story, the narrative. Whereas in a traditional system, they make it cumbersome to capture the narrative. They are more focused on structured data, which it's often unreadable. So we've often replaced one form of illegibility, handwriting, with another form of illegibility, and that's meaningless data, based on templates. And so as you go into a direct practice, the narrative is and as you receive reports from other practices, that's really what you're interested in. And that's true quality, true value, and far more efficient.
Okay, we have one right there. Go ahead.
I'm an internist in Houston, and I've been doing DPC for about 5 years. I think it's easy for all of us to begin to communicate with patients instead of going exam room to exam room via email and telephone, but I haven't yet reached out to video conferencing. Any advice in that domain, how to do it? You have to think about going through different platforms for cell phones and internet. Where's the best resource to work through that? Because patients would like it to not have to come in the office and still be able to get the expression on their face when they complain of belly pain and where they put their hand and what part of their hand they use when they touch their belly,
Correct, and again, with the education, when they sign the waiver when you start this, again, make sure they're in a secure environment too, first of all, so that was important. But the, it's easy if you're like part of a big healthcare system and there's, companies like MD Live, I love that company too, and they've got these very expensive systems and they've got their specialists at night when the system specialists want to go to sleep, and the primary care doctors can interact. But for somebody who's going to be in a small practice to use this, that's where, again, you can Google, so VC, VSEE, was one that I really liked. It was about $50. They have to be, obviously, secure networks, and again, you don't want to have to pay for that. So for $50 a month, you have a secure network, but it's essentially what you want is, I'm blanking out, what's the phone, I've never used it before, the phone face-to-face?
FaceTime.
Yeah, FaceTime. So sorry. So it's a secure FaceTime, and that's, I think, all you guys want. And then you're going to document the way that you want to document. And there's various ways to do that. I would say, you would set it up with your office where, Mrs. Smith calls in, they call to the front desk, and you can set up a digital appointment for something. Or, for me, I start and change medications a lot, and I want to interact with that patient in 2 weeks. I have them come back in 6 weeks because I don't have any spots in 2 weeks, but you could do it with telemedicine telemedicine very quickly, or they're 4 or 6 hours away. I think if you start doing that, again, for $50 a month, I think your patients are going to love it. And it's kind of like, at the lunchtime, we was talking about, the disincentive and the going across the street because someone else is doing it. If you guys start doing that and offer that to patients, and then the businesses start coming in and they're looking for the best DPC practice to use, and oh my God, what do you mean my employee doesn't have to actually leave the office? They can actually interact with you and they're not losing any of that time out of work. I mean, it's going to get there. The question is, when do you want to start using that?
I would like to comment on that. We had telemedicine when I went into practice 30 years ago. It was the phone. And I would argue that, that's probably the 80%, either phone or texting more now. And actual video telehealth is something you ought to have on your menu. But in most DPC practices that I'm in, that tends to be one, patients want to know that they can have it, but they are far more inclined to phone, text, or email. And being able to do that efficiently and well, I think should be your first priority. But some type of, and there are several off-the-shelf solutions out there that you can utilize that are fairly minimal in cost.
Yeah, where it's really helpful too, it's, as I mentioned, nursing home, elderly, difficult to get. When my patients drive 4.5 hours with multiple sclerosis in a wheelchair, that's somebody, that's right. So somebody's leaving work to come drive my patient up. Let's not even talk about gas and the environment and all the other things, coming to see me for 4 hours. But there's a lot of patients you can think about that it would be unbelievably more convenient for them, or how inconvenient it is to actually come to your office.
I'd also like to comment a little story. A good friend of mine is an employee of one of the major employers in my community, and they were telling me about the announcement of their health plans for 2017. They were all excited that now a part of their health plan is that they can have telemedicine visits for just a $20 copay. And it's like a $30 copay if they see their primary care, $40 if they see their specialist. And, I just hit the roof. I said, why couldn't that employer agree to pay the patient's primary care doctor for offering telemedicine services, whether that's phone call or video, for the same offering, and have continuity of care and all the benefits? It's really pretty crazy. And I think it's to us to get out there, talk to the employers, and offer some type of service which is going to be clearly superior to an unknown who can't provide continuity, who can't make the referrals and do all the tracking that you can do. I think there's a real opportunity there, because that's hot now with employers offering these telemedicine services. Go directly to the employer. I intend to do that in my community and say, look, why don't you offer this? You'll have a better outcome.
Go ahead.
Thank you. I think you just addressed part of my question. I'm Claire Coco from New Braunfels. I am for using telemedicine. My husband is a psychiatrist who's done telemedicine for years. And the issue that I have with it is related to the teledoc type services and the $20 telemedicine that replaces a primary care visit. I've had patients who've been taken care of by, I use that term loosely, by the teledoc service. So they ask them a few questions. They send out a Z-Pack and a Medrol dose pack. And those people who are involved in the quality programs know that that's like a strike against you if you use a Z-Pack for a cold. So, and then of course the patients come in to see you 5 to 10 days later, no better, and either sicker or just have lost time. So I just would want to know what kind of standard are we setting when we're using those types of services, and what kind of accountability is there? I don't think the patients are actually thinking that that doctor is accountable for that care. I specifically asked them, are you going to sue that doctor for delay in diagnosis? And they're like, well, no, of course not. It's just a guy on a telephone. It's not really a doctor. I'm like, well, yeah, they still are, accountable. So, but the patients aren't looking at it that way. And I don't think the employers are either. So I would just have I would want to know the answer to the question, on the slide you put up about Teladoc, you said that a case was filed, but you didn't give the outcome of the case.
I don't know if the case has been settled, so a Texas doctor may know the answer to that. They are allowing? Okay. Well, so I guess I should change my talk because I need to add in, you're correct. I think we do the best evaluation face-to-face in the room, and I would add to that, I guess, you do the better evaluation face-to-face in the room with your own patient or with telemedicine with your own patient. We've all covered for our partners, and a telephone call from my patient is a lot different than a telephone call with my partner's patient, even if I have access to the EHR. So I completely agree with you. It's not supposed to, I would not want to be in a practice where all I did was telemedicine for neurology patients that I've never seen before. So I think that for you guys, this is an incredible opportunity to follow your patients closer and do what you feel is the best job for them. And if you think that telephone and are getting them to come in, but if they can't come in, again, if it's, again, nursing home, there's so many things you could see visually with just a snapshot, but I completely agree. The flip side of that is I would say if we don't have places like MD Live and Teladoc and things like that, they're going to be seeing doctors in other countries and other places anyway. So it's you know, it's not perfect, but I think it's getting to be you know, at least very safe and extremely helpful. But
Well, if there's no other questions, let me throw one more out for the Brain Trust here. If you know, one big difference between the telephone going back 30 years and the modern stuff we have right now is the ability to capture that as part of the medical record. So my question to you is, what should the ground rules be for that? I mean, if we're being videoed constantly as we interact with patients, what are the implications? How do you feel?
Well, I mean, the assumption is that whatever documentation you're using, pen or computer, that visit ought to be documented as well as any other live visit.
But with the video or just with your notes?
As far as the video being documented?
Yeah, or the audio conversation, because that can be captured.
I don't know of any of these platforms we're talking about that would do that. Again, I know what technology can do, but I don't know how it does
Right.
it. And I
Question is
think
what it
that
should
would be
do.
extremely high volume of data, wouldn't it be, that it would have to store?
Yeah, but storage is getting so cheap, it could be done if it should be done.
I
And
mean,
that's a big
you can make the
question.
argument that legally maybe you ought to have every encounter, even with the patient, video and audio taped and stored. If
Double-edged sword, I don't know. Yeah, body cams, right, exactly. It's the same sort of ethical question. All right, thanks very much.